First, we're going to start off with a few introductions, just so we have an idea of where everyone's from and what your role is, where you work, whether you are a respiratory therapist, physician, nurse, who would like to know about our audience. This is the first mechanical ventilation symposium that's being held at this conference, and we want to learn from this, and then hopefully the next time we can actually streamline things and provide even more interactive things with you. This is a very informal, right? We want to be friends here. So if you have any questions while we give the lectures and the talks, please feel free to put your hands up. So myself, my name is Thomas Pereno. I'm a respiratory therapist from Canada.
Lorenzo De Sorbo. I'm also from Canada, but actually I'm from Italy. So I have a different accent.
I'm Martin Erner, also from Canada, but originally from Switzerland.
Can you speak apologist?
Excellent.
From here in Kuwait.
Very possible.
Okay.
I'm Claudia, and I'm a physician based in ICU Brazil from Mati Juma, Kuwait, Kansas City.
Excellent.
I'm Dr. Kuka, I'm an anesthesiologist in Cancer Center.
Cancer Center.
We're also covering the ICU related.
Excellent.
I'm Zahra Al-Mazri, respiratory therapist from Saudi Arabia.
Nice to meet a fellow respiratory therapist. No judgment, no judgment, but I get excited, you know.
Hello, good morning. I am Joe Neal from Amity Hospital. I'm a clinical technician in ICU.
Dr. Dasha, from Minnesota, intensive respiratory.
Dr. Henge here, the ICU registrar from Amity Hospital.
Very nice.
Hi, my name is Shahad Sleiman. I am a respiratory therapist from Saudi Arabia, but I'm living in Kuwait.
Oh, okay.
Physiotherapist Nora Buderi, working in ICU and wards, chest disease hospital. I'm Mary Jo Gagliardi, urologist from Royal Hyatt Hospital.
Excellent.
I'm speech pathologist, Mira Mudari, from the Farmania Medical Wards and the ICU.
Excellent.
I'm Rebecca Lumperi. I am respiratory therapy from Saudi Arabia. I work ICU and General Hospital.
Hi, I'm Nurse Sarah from Surgical ICU, Jahra Hospital.
Excellent.
Mohammed Zaza, anesthesia resident.
Excellent.
Hassan Al-Saraf, trainee at Jabra Ahmed Hospital.
Welcome. All right, well, we'll get started into some of the, oh yes, and yourself.
I'm Mujahid Al-Busaidi, I'm one of the speakers.
Okay. We have not met formally yet, so
it's good.
I'm going to, I want to unplug this because it has some background noise.
And there we go.
All right, so we're gonna get started. As I mentioned, we're gonna try to be very informal. We try to keep things on the timeline, but we're not overly picky with it. We'll try to do 2 lectures, get some feedback from you, and then we'll take a short break and then come back and continue. So we'll start off with
So the first talk, please interrupt me anytime, is on non-invasive ventilation. I don't have conflict of interest related to this. Okay, so 2 words on, if you like history, non-invasive ventilation has been applied for many years. You see some report from 1744. I wasn't even born. And so they were using this kind of bellows to inflate the lungs. They understood right away that they were causing many patient pneumothorax, and so for a while it was abandoned. Okay, and there are other ways of, just to clarify the concept of non-invasive ventilation. You can have negative pressure non-invasive ventilation, where you apply systems that decreases the pleural pressure by creating negative pressure around the body, like they were doing with the iron lung, okay, till, for example, sometimes in the polio outbreak. But there are abdominal respirators or ventilators with these system that can help the diaphragm to move in the certain direction to support the patient. Okay, but what actually we want to talk about today is non-invasive positive pressure ventilation, where we apply positive pressure and at the mouth of the nose, okay, and create a gradient, okay, in the lung in order to create flow from the atmosphere to the alveolar units. Okay? So non-invasive positive pressure ventilation. This is very important. So what's the difference? If you want to pick what's the difference between positive pressure ventilation and negative pressure ventilation? You know, if you can mention one potential difference.
I think now you're always doing positive pressure.
Now we go all, but from a physiologic perspective, what could be a difference? So if you ventilate someone with positive pressure, so you put pressure, okay? So increase the pressure in the atmosphere, so then the air goes down, so you push air in, versus you help the patient creating negative pressure, okay, just like in the iron lung, that creates negative pressure, so you suck air in. Is there any physiological difference?
It's nature and against nature. Negative pressure is nature with the normal physiology.
Okay, yeah, so it's true, okay, because our way of breathing is to create negative pleural pressure, so we suck air in, but there's nothing pushing the air into our lungs. And does this difference have a physiological consequence? Perfect, okay, so excellent. So the cardiovascular system reacts in a different way. If we put positive pressure ventilation in certain areas of the lung, especially the one that are more ventilated and less perfused, that's on West 1, if you remember in the physiology course, may have more dead space. So the capillary, okay, alveolar capillary gets squeezed, okay, whereas in negative pressure ventilation, everything is undergoing negative pressure, so there is a vasodilation, okay? This with the same sort of breathing. Okay, good. So positive pressure, a bit of literature. So these are the references for this talk. Lots of nice review. The latest one published in New England by some of my colleagues in Toronto, and we'll have more. So this is the outline. So we'll talk about a bit of rationale, equipment, patient selection, initiating non-invasive ventilation, and how to monitor. Okay, so advantage of non-invasive ventilation versus invasive ventilation. So avoids complication of intubation, especially after airway trauma, maybe some pneumonia. There are because we think this is the VAP, ventilator-associated pneumonia, is actually endotracheal tube associated pneumonia. So if you don't have an endotracheal tube, the incidence may be reduced. Avoids complication of sedation, may have more patient comfort, may allow eating, talking, coughing. So if it's a medication, it has the best onset and offset time, because if you want to apply, apply. If the patient doesn't want to, you can remove it, apply anytime, and the effect is immediate. Okay, so that's the charm of non-invasive ventilation. Okay, that you can apply and have immediate effect, and then if the patient doesn't tolerate, you remove it. Okay. Any question about this? So one caveat here is that many of these advantages, okay, were very clear 20, 30 years ago, where invasive mechanical ventilation was provided with heavy sedation, larger tidal volumes. Okay, now also the management of invasive mechanical ventilation is different. Okay, and so in certain areas, you will see some data. The advantages, disadvantages, the risk-benefit profile is a bit different. Okay, so the first report of non-invasive, positive pressure non-invasive ventilation in acute settings is from 1989. I was born, unfortunately, by Umberto Meduri, who's a scientist, Italian origin, and that moved to the US. Okay, and after that, many papers started being published. So look, okay, and only in 2021, almost 1,700 papers published. Okay, the use of non-invasive ventilation has really taken off, and you can see this confirmation. But you see that over time, for certain indication like COPD exacerbation, keeps going up. For other indication, there is a bit of plateau, okay? And we'll see why is that. Okay, equipment. So this is very, very important, okay? So interfaces, there are many different interfaces, and they are key to the success of non-invasive ventilation, okay? And we'll see a slide at the end, part of the challenge of providing non-invasive ventilation the right way is to find the right fit, okay, of the mask on the patient. Everyone has different anatomies, and so really, the clinician at the bedside needs to find the right mask that fits that particular patient, because the leaks are really compromising the success of NIV, okay? And so there are some that look very good, like the full face mask is very good if you play hockey. No, I'm sorry. Because it fits very well, and some others is a bit more difficult to fit. There are also nasal one, but if the patient is breathing with the mouth, that is not as effective. And then one of my favorite, the helmet. Do you use a helmet? No? Okay, so after COVID, nothing? Okay, so I'll go, why you don't use the helmet? Because it's not available, you don't believe in the helmet, or?
Difficult to put on the patient sometimes.
Okay,
That sometimes comes with skill the more you do it, but that's been some complaints I've heard, is that when they first try to use it, you're so used to just putting the mask on, and when you start adding this, it's like starting to prone for the first time. Nobody likes to do it, but how many people believe proning is beneficial? I hope everyone will put their hands on. So,
okay, enough of my slide on helmet.
that's why I was preparing them for you.
Yeah, okay, these are other interfaces, and then also I put here the iFlow nasal cannula is not really, I don't know, is non-invasive ventilation or not, we don't know. There is some data showing that it provides some pressure, some PEEP, okay, especially if the patient breathes with the closed mouth, and this is due to the turbulent flow that the OptiFlow creates in the upper airway, which is also the mechanism by which the dead space is reduced, because there is washout of CO2 in the anatomical dead space, and has other advantages like humidified and warm gas. The high flow, why high flow is so successful and well tolerated? Why we like this high flow, up to 60 liters per minute? What's the advantage of having high flow instead of low flow? Low flow is defined by oxygen delivery device that providing flow up to 10-15 liters per minute. Why increasing that may be good?
I believe.
Okay, so there could be additional PEEP by the turbulence created by this high flow. What else?
Washing out the anatomical CO2.
Okay,
And also another thing is exceeding the patient or the person airflow.
Perfect, so that's a key mechanism, okay? So to match the peak inspiratory flow, okay? The peak inspiratory flow patient that have some respiratory distress can reach up to 120 liters per minute in very, very few patients. Most of the patients have 60 or less. That's why 60 is good, because meets the needs of most of the patient respiratory distress, okay? So the patient wants, can you imagine, the patient breathe, 30 liters per minute, peak inspiratory flow, 30 liters per minute, and we give oxygen only 15 liters per minute. That means the patient inspired 100% with 15 liters and room air for the other 15 liters. So even the FiO2 that we think we are giving 100%, but actually is less than that, okay? Whereas if we match the peak inspiratory flow, first of all, is more appreciated by the patient in terms of mechanics, okay? And the FiO2 that we provide is more precisely measured, okay?
I can ask, high flow really considered as ventilation wise. I don't think he can.
Yeah, so that's a very, very good point, okay, for several reasons.
30 to 40% of FiO2, cannot depend on CO2 wash in high flow. If there is respiratory failure due to ventilation issue.
But
Yeah.
Because in the pediatric age group, the maximum flow for us not exceed this limit, about 40 liter per minute is the maximum.
Okay, yeah, so OptiFlow can go as high as 60 liter per minute and the FiO2 can reach 100%. And because of the effect of positive on PEEP and some increased CO2 clearance, it can be considered, okay? So for example, in Canada, in Ontario, for billing purposes, we consider in certain patients as positive pressure ventilation, okay? Just because of the data on PEEP. But I agree, I'm also a little bit not super convinced that that's the
In adult patients, there's ongoing data looking at the ability for high flow to reduce CO2. So there's some non-inferiority studies which basically look to see can high flow reduce CO2 similarly to NIV. Maybe not as good, but similarly. And there's promising results. What we're finding more and more with COPD patients is the higher flow may not be better. So going to 50 or 60, you think, oh, I'm gonna blow off more CO2. They're finding that something closer to 30 in COPD patients may be more effective. And this could be due to their difficulties with exhaling because of their lung injury or their chronic lung injury. So we still don't know how good it is at ventilation, but we don't typically classify it as ventilation. But the physiological benefits are there. They do reduce CO2, but whether or not it would replace BiPAP or NIV in the emergency department, I don't think we're there yet. We don't know the optimal level, and NIV is so proven to reduce intubations, we shouldn't forget about that.
Any more questions?
Yes, according to interfaces, we suffer in pediatric age group with interfaces so much fail due to leakage, number one, toleration, not tolerated well. Also, we try to change many interfaces to fit with it. If you, your experience, have any suggestion to overcome this?
I don't have any experience in the pediatric population, so forgive me, but even for adult, it's not as easy as you think. So, for example, I work in my old ICU in Torino. We were doing non-invasive, pretty much everyone was receiving non-invasive ventilation before or after intubation or even as his own supportive strategy. But we had, 20 different kind of interfaces, and we were trying all of them till we were successful, okay? So that's the only thing that I suggest. Okay, so how it works, the CPAP, we mentioned some mechanism of high flow nasal cannula. How about the non-invasive ventilation with the face mask or helmet, okay? So counterbalance the mechanical load by intrinsic PEEP, okay? Imagine a patient that has intrinsic PEEP in the asthma or COPD exacerbation, in particular COPD exacerbation. Let's say the patient has 10 of intrinsic PEEP, okay? So before generating flow, the inspiratory muscle needs to generate 10 centimeters of water of negative pleural pressure, okay, before creating any flow, inspiratory flow, okay? So that's a lot of work for inspiratory muscle. So if we apply an external PEEP, we reduce, okay, we match the intrinsic PEEP, so the work of breathing decreases. So that's one mechanism, okay, especially in patients with expiratory flow limitation. Atelectasis, because counterbalance atelectasis, because it maintains some recruitment, may keep the airway stented in asthma or COPD exacerbation, or even in patients with hypoxemia respiratory failure. In patients with higher chest wall mass, like in obese patients that tend to collapse, may keep the airway stented open as well, recruitment, but may induce alveolar hyperinflation, okay? Because it maintains higher alveolar pressure and has hemodynamic effect, decreased preload noise and afterload, okay? So because of, if the create all these effects, these have direct consequence of reducing work of breathing. Okay, these very clear. Okay, so for example, let me see here, transdiaphragmatic pressure, you see, tends to decrease as CPAP. Then in this paper, they have initial setting, baseline oxygen, CPAP, pressure support 10/10, pressure support 15 over people 5 and final. And you see there is a decrease in pressure time product, all the variables that you can measure to monitor work of breathing and distress. Okay, and you see that as you feed the patient with the right settings, okay, the work of breathing decreases. But you can really increase hyperinflation, and sometimes this may be associated with failure. Okay, this very nice paper from Carteau in France. Okay, you see. Paper where they provide non-invasive ventilation in patients with acute lung injury, so acute hypoxemic respiratory failure, excluding cardiogenic pulmonary edema. You see in black here are the patient have tidal volume greater than 12 ml per kilo of predicted body weight. So it's not a small percentage, it's almost 20%, 15-20% of patients that have tidal volume greater than 12 ml per kilo. And here, if you stratify patient by severity of hypoxemia, mild versus moderate to severe, the patient with moderate severe hypoxemia with higher tidal volume, they're the one failing the most. Okay, so and this may be because failing because instead of maybe it reduced the work of breathing, but it was worsening lung injury by ventilator or ventilation-induced lung injury. Okay, this is an hypothesis that didn't demonstrate that, but this suggested that also during non-invasive ventilation, there might be some risk of ventilation or ventilator-induced lung injury. Helmet. So 2 words because I'm trying to convey, I don't have any interest in or conflict of interest with the company, although the major company from building helmet is Italian, but that's my only conflict. It's very nice because it's a plastic bag, okay, hood that goes around the face and the head of the patient. So it's very comfortable because it avoids the pressure of the face mask on the nose, especially on the nose bridge. Okay, the patient can talk, okay, whereas it cannot talk with the face mask. Okay, can actually eat and drink through this oblong window that can be unscrewed and then screwed back in. Okay, so it's very, in theory, is much more comfortable. There are a few things for which maybe is instead increasing discomfort. One is that the patient has a plastic bag around the head, okay, which can create some claustrophobic effect. Second, there is lots of noise in these because there is very much flow, okay, going in through the helmet, and so it's very, very noisy. So in expert centers, they put air filter in the inspiratory limb to reduce the noise and maybe the earplug in the patient, although that earplug defeats the purposes of communicating properly with the patient. And then it's relatively warm inside, okay? So these are the disadvantages, okay? But we can increase the people with non-invasive ventilation. If we increase the end expiratory pressure higher than 10, the leaks are gonna increase no matter what you try to do, okay? Because the pressure is too high. Whereas with the helmet, you can increase up to 20 with no problem, okay? So the amount of meningeal pressure that you can maintain is significantly higher. It's a bit more comfortable, so usually it's tolerated for longer hours than the face mask. The problem is it increases function of that space because all the volume that you see of the helmet is all that space, okay? So to avoid that, you need to maintain very high flow, at least 30 liters per minute of airflow through the helmet to wash out CO2. Otherwise, the patient is going to rebreathe his own air. Okay, this is the same concept that applies on the airplane. When the people are on the airplane, okay, all the airplane is dead space. Okay, because people are rebreathing their own air. That's why they need filters and very high flow to wash out the CO2. Otherwise, everyone will be narcotized by, especially if you come from. Maybe that's why I fell asleep. Okay. The interaction may be problematic, and that's why the first time that we tried, the providers tried the helmet, are always scared because the interaction may be between the patient and the ventilator with the helmet may be problematic because of the compliance of the plastic. It's not a solid plastic, but it's a very fluffy, okay? And so let's say that the patient has a peak inspiratory flow of 60 liters per minute. And the flow bias inside the helmet is 30 liters per minute. When the patient takes a breath, the plastic collapses on the face. Not good, okay? So you really need to have very high flow, at least 30 liters per minute, but better if it's 60 or even 100 liters per minute. But that creates lots of noise, okay? So noise, claustrophobia, and then it's almost impossible to measure accurately the expiratory total volume, okay, because of all the dead space. Okay, the noise, I already said, so filter, okay, if you ever use it. It decreased the workability. This is a very nice paper by Domenico Vieco that worked with Tom and Laurent Brochard. I published this when I was back in Rome with Antonelli. That's one of the investigators that invested his career on non-invasive ventilation for hypoxemic patients. So compare the physiologic effect of high flow nasal cannula versus NIV provided with the helmet, okay? And show that the helmet really reduces the work of breathing in a very significant way, whatever measure or surrogate you take. This is a slide showing that you need at least 30 liters per minute, okay? You see in a helmet, okay, versus the non-invasive mask, okay? So you see non-invasive mask, the inspiratory CO2 is very low, with the helmet is high, but if you increase the flow, it's getting low, okay? Because the washing out of the CO2. And this is a nice paper by Vargas and Brochard a number of years ago, comparing non-invasive face mask versus helmet and changing the setting of helmet. So to match on non-invasive ventilation with the helmet, to match the physiologic effect of face mask, you need to increase the settings by 50%. So if the PEEP in face mask non-invasive ventilation was 10, you need to use 15 to have the same effect. And the same for the pressure support. The driving pressure was 10, you need to use 15. Yeah.
Does that apply to all ventilators?
All ventilators, okay? All ventilators. And yeah.
That one slide you had sort of example settings to use with the ventilator. So with NIV, you start, 4 or 5 centimeters of water for expiratory pressure. And as Lorenzo nicely pointed out, if you get close to 10, your leak is almost impossible. Most studies show that anything above 8, the tolerance goes way down because of the leaks. But with this device, the starting PEEP in the example is 10.
10. Yeah.
So that would be like your 5. You start at 10 because it's maintained with flow. The PEEP, when you use NIV mode on a ventilator, it maintains PEEP with flow rather than using the expiratory valve the same way that not how invasive would do it. So 10 centimeters of water, and then the pressure support on top of that was 10 to 12. So if you started, again, really the idea is the PEEP. You will need to start that baseline flow to maintain the setting higher.
Okay. Any other question about this?
I think for this mask and for the helmet, I think this mainly used for the highly infected airport patients. It will be.
That's one of the. If you want, that's one of the advantages, right? Because without air leak, okay, there is less airborne contamination.
With the
for sure.
Everything was.
For sure. Okay. So, for example, that's a very good point. during the COVID pandemic, helmet in many institutions was allowed as a non-invasive tools, whereas the face mask was not allowed because of the air leak and air bonus. That's a very, very good point also, yeah. Okay, and the helmet, okay, talking about ventilator, okay, here. So the helmet ventilation can be provided with invasive ventilators for invasive, non-invasive ventilation. If you only need CPAP without driving pressure, the helmet can be provided only with the oxygen plug on the wall, okay? And the flow meter. And so you don't need a machine to be able to provide CPAP, okay? Even at 20 of people just with the helmet, okay? Instead, for non-invasive ventilation, so if you add inspiratory pressure, so if you add the driving pressure on top of your and expiratory pressure, non-invasive ventilation, you need a ventilator, okay? A ventilator can be a regular ICU ventilator in the non-invasive modality, okay? Or a specific ventilator for non-invasive ventilation, okay? So usually these specific for non-invasive ventilation have only one limb, okay, whereas the other have two limbs. And what's the other difference between ventilators in non-invasive mode versus invasive mode? There's one major difference. The rest is all the same because the settings, the modalities, you can apply pretty much the same of non-invasive also to same of invasive ventilation to non-invasive. But what's from a mechanical perspective, what's the major difference?
The space?
No. Yeah, the compensation for leak, okay, which is very, very good up to liters per minute in non-invasive mode, whereas it's not tolerated at all in invasive modality. So what do you use specific in your practice? Do you use specific ventilators or use the invasive in non-invasive? Okay.
Many places have both.
Yeah. Okay, so now patient selection. So we need to have the proper, so there are absolute contraindication to non-invasive ventilation, okay? So if the patient has respiratory or cardiac arrest, okay, it doesn't work. And if the mask doesn't fit, okay? It needs to work because otherwise you just increase the resistance to the work of breathing of the patient, okay? And there are relative contraindications if the patient is unstable, not cooperative and agitated, severe decrease LOC, so inability to protect airway because we rely on airway patency for the flow.
So for the speech pathologists in the room, this is obviously a very important.
Yeah. So swallowing impairment, okay, because it may increase the micro or macro aspiration. Okay, good. And then appropriate disease. Okay, so there are guidelines. Okay, see here Bram Rauscher, also from Canada, from Hamilton, Laurent Brochard, so many important people that really established, you see Antonelli and others, established the role of non-invasive ventilation in critical illness. So let's go through these guidelines. So recommendation 1A, so must be applied for patient with COPD exacerbation and hypercapnic respiratory failure. Okay, this stemmed from the first paper, okay, in 1995 by Laurent Brochard. Very strong signal in applying non-invasive ventilation in COPD exacerbation, in reducing the need of intubation and reducing mortality. Okay, this really changed the clinical course of patients with COPD exacerbation. It's an incredible step forward in clinical, in ICU. And this has been replicated in many other studies with these meta-analysis showing very, very strong effect. And so, yeah, we should always apply in patient with hypercapnic respiratory failure. No, the suggestion is not to, the recommendation is not to use it to prevent hypercapnia, okay? If they're not hypercapnic and not acidotic, meaning the pH is not less than 7.3, there's no real benefit. Cardiogenic pulmonary edema, also very important, okay? CPAP or non-invasive ventilation are equally effective, okay? But there is a strong evidence and recommendation for them, okay? So these are only 2 strong recommendations for non-invasive ventilation, okay? All the others have not, all the other indications that we're gonna talk from now on are not, recommended based on very strong evidence. Okay, guidelines also for the high flow nasal cannula, there are many, so you can read. Okay, and nice paper in hypoxemia respiratory failure. So what should we do in hypoxemia respiratory failure? Should we use low flow oxygen, high flow oxygen, or non-invasive ventilation? So Dr. Frat in France randomized the nice paper, randomized clinical trial randomizing about 100 patients to high flow, standard oxygen, non-invasive ventilation when they had high respiratory rates, so some sort of respiratory distress, hypoxemia, PF ratio less than 300, and not hypercapnic. Okay, so the rule excluded all the patients with chronic respiratory failure, and by clinical history or by CO2, and show that there's no difference. Okay, overall there's no difference, but the high flow nasal oxygen actually behave much better, surprisingly, than standard oxygen, even non-invasive ventilation. Okay, and there was a significant difference in the subgroup. It's a subgroup, so it's only hypothesis generating and not really determining change in the clinical practice in patients with PF ratio less than 200. Why do you think the high flow could have performed a little bit better than even non-invasive ventilation?
The actual muscle would work.
Sorry?
The actual muscle working with the support.
Yeah, but non-invasive ventilation provides support.
But it will rest the muscle of breathing.
Yeah, but non-invasive ventilation arrests the muscle and did worse than, you see, the cumulative incidence of intubation is higher, okay, not significant, but it's higher in non-invasive ventilation than high flow.
Increased risk of aspiration.
Okay.
Depends upon the patient.
Hmm?
Depends upon the patient.
Okay, but this is an overall effect.
Think about one of the slides he showed earlier, one of the issues with non-invasive ventilation in hypoxemic patients. What was the result of them breathing sometimes?
Yeah, so maybe the tidal volume was excessive, actually it was worse.
CO2 retention will be high.
No, there's the potential for lung injury.
For lung injury, right? They may have received higher than expected tidal volume, so worsening, exacerbating lung injury. Or simply the dose is different, because the non-invasive ventilation is tolerated less than, for sure, less than high flow. So high flow, so in these protocols, patient needed to be on these treatment at least for 48 hours. And the compliance with high flow is very high, 48 hours, whereas non-invasive ventilation, you get it for a few hours and the patient cannot wait to remove it, okay? So the dose actually of intervention is probably less.
The feeding also it will be problem.
Sorry?
The feeding also it will be problem.
Feeding, yeah. Okay. Okay, so we can skip this one. Okay, so during COVID pandemic, lots of study on optimal treatment for support. This is a nice paper from the group of Dan McCauley showing that CPAP versus conventional oxygen was better. Okay, high flow versus conventional oxygen was better. No comparison between CPAP and high flow. So we really don't know. Maybe we should do CPAP, maybe we should do high flow, but we don't know exactly which one of the two is better. Okay, so in patient with immunocompromised status, okay, we all, I believe, and many of my colleagues strongly believe that was one of the main indication in the old guidelines was indicated with the recommendation 2B, meaning that there was some evidence that, and the evidence was the famous Hilbert paper on New England Journal of Medicine in 2001, showing that non-invasive ventilation in hypoxemic patient with immunocompromised status was improving oxygenation, reducing the incidence of intubation and the signal of mortality, although it wasn't power for mortality. But a more recent paper by the group of Ili Azoulay showed no difference. Okay? And again, in 2001, the way invasive ventilation was provided was very different from the 2020, I don't remember here, 20 something, 22, 23, when this paper was published, okay? So as our practice evolves, okay, and the risk, we always need to be critical on gauging well the risk and benefit of each strategy. Again, immunocompromised patient, here again another study, high flow versus non-invasive, and no effect. So in acute respiratory failure, okay, should we use to prevent failure post-extubation? So what do we do for post-extubation? Patients that are invasively ventilated, they're weaned, we extubate them. So should we use non-invasive ventilation or should we not use it? So in patient with hypercapnic respiratory failure, okay, we can extubate the patient on non-invasive ventilation. So not extubate and then wait for them to decompensate, but extubate directly on non-invasive ventilation. This is a nice randomized trial by Stefano Nava. So he randomized patient to a patient that had need of invasive ventilation for COPD exacerbation, even if they didn't, when they met criteria for weaning, even if they didn't pass the spontaneous breathing trial, okay, they were randomized to be extubated to non-invasive ventilation or remaining intubated with progressive weaning, and show that with non-invasive ventilation, the duration of respiratory support was significantly shorter. These are many slides showing that if you instead extubate the patient, okay, and wait and the patient develops symptoms of acute respiratory failure, immunoexacerbation, you should not use non-invasive ventilation, but you should reintubate, because the mortality is summarized here if you want to read it. The mortality of patients that got reintubated, okay, was significantly higher, even in the analysis they did when correcting for baseline severity, okay? So never use non-invasive ventilation for extubation failure.
Quick questions for the respiratory therapists. How many of you have been asked to start BiPAP 5-6 hours after somebody fails extubation?
There are some.
I'm gonna put my hand up.
Yeah.
So this is very important because the outcomes in those patients are actually worse. So we should be advocating that, listen, this patient has failed. We missed the window of providing support. And what he's pointing out is that if you extubate directly to NIV, or even in some cases high flow, which you may talk about, that is where you can reduce reintubation. But if you wait until they're failing, that's actually a bad thing to do, is to start NIV. The data suggests you may be causing harm.
This depends upon the case, no? Because of brain injury patient, we cannot put in one BiPAP because of it will cause high CP.
Mm-hmm.
So that is.
But you could try high flow nasal cannula. I think the idea is that supporting patients with more advanced respiratory support, like high flow or NIV, is you always, if you're going to try it, do it immediately after extubation. Once they start to fail, it's probably telling you they weren't actually ready for extubation, but we gave them the chance. But providing NIV in that case can be harmful.
So Tom mentioned high flow nasal cannula. So there were several papers showing benefit of high flow nasal cannula versus low flow oxygen post extubation. Okay, but more recent studies, and I'll show you two. Okay, one published in Intensive Care Medicine, one in JAMA, show that actually so in this trial, for example, they randomized patient to Optiflow versus non-invasive face mask mechanical ventilation in patients that were high risk of of intubation. So the high risk with at least 4 risk factors for extubation failure, including age, okay, high Apache score, high body mass index, inadequate secretion management, difficult to prolong weaning, heart failure or chronic heart failure, moderate severe chronic pulmonary disease. Okay, so patients that have high risk of extubation failure were randomized to Optiflow versus non-invasive ventilation, and non-invasive ventilation was superior. Okay, and this has been confirmed in a recent journal paper by Arnaud Thiel, a French intensivist, very much expert, published tons of paper on non-invasive ventilation. Okay, so high flow is a cannula or non-invasive ventilation alternated with high flow, the difference is striking. Okay, so I would suggest this is not part of guidelines because this paper came out after the previous guidelines were published. Okay, so patients that have high risk of extubation failure, you need to extubate directly on non-invasive ventilation. Okay, so not only in patients with COPD exacerbation that are failing SBT, those you can extubate even if they fail SBT, although there is only 1 or 2 papers. But anyhow, for sure the one high risk of extubation failure, you can extubate to non-invasive ventilation, the requirement for intubation decreases. Okay, post-extubation again. Okay, so one of the last slides, non-invasive ventilation, this is very, very recent data, okay, for pre-oxygenation, okay? So very nice paper by the group in the US, so multi-center, 24 centers, emergency department or ICU, critically adults requiring intubation. They were randomly assigned to receive either non-invasive ventilation or not for at least 3 minutes, okay, before induction. Okay, the settings of people 5, driving pressure of 10, respiratory rate, back heart rate of 10, and FIA to 100%. Hypoxemia during intubation defined as oxygen saturation less than 85% from induction to 2 minutes after intubation. Okay, patient characteristic, we skip these, and so significantly less hypoxemia during intubation. Okay, so quite a strong effect. This may change. They didn't compare non-invasive versus Optiflow. Okay, so we don't know if pre-oxygenating with Optiflow may exert the same sort of benefit, but this may change clinical practice. Okay, this is subgroup analysis, so in certain subgroups that may very, very physiologically sound use. Okay, so initiating an IV, so apply this. This is a slide from a Meduri paper, okay, that listed all the things that the clinician needs to do to initiate non-invasive ventilation. And I don't go through the details, but it takes time, okay? It's not something that you apply and you walk away, okay? It's easier to manage a patient that is intubated because the patient is sedated or paralyzed usually just after intubation. You set the vent, you can walk away and wait for the ABG. Non-invasive ventilation takes at least half an hour coaching, finding the right mask that fits, and start with low settings and then increase setting, making sure that the synchrony between the patient and the ventilator is in a good setting. So it is very time consuming. Same message. Monitoring, and we monitor, of course, gas exchange, hemodynamics, level of consciousness, and work of breathing. Okay, and these are the parameters that continues to be assessment. Okay, usually we don't keep the non-invasive ventilation for days and days, although certain centers they prolong up to 4 or 5 days. But usually the effect, if it's truly beneficial, is immediate after a few hours. Then you can decide if to keep it for a longer period of time, and then in the first few hours usually is where you see the effect. There are side effects, especially with the face mask. So the bridge of the nose and may have pressure ulcer. So usually we put tapes or something to avoid that. And gastric insufflation is another one with vomiting and microaspiration. Okay, so it's for selected patients, selected disease, selected physician or clinician, and selected facility. Okay, thank you.
Okay. We're gonna jump right in, because after this one, we'll take a short break. Everyone can get up, move around, grab something to drink, which I'm gonna do before you, I apologize. So, we wanted to start with non-invasive ventilation. This was, of course, a mechanical ventilation course, but we couldn't ignore the fact that we provide ventilation non-invasively before we get to this point. We don't want to just jump into invasive ventilation, but one of the most important things to remember when providing mechanical ventilation is the equation of motion. Can anyone tell me the equation of motion off the top of their head? Put your hands up first and then I'll ask you, but you don't have to if you don't want to. Yeah?
Delta V, change in volume according to change in pressure.
Yeah. Okay, so now I'm going to simplify it. Which two pressures make up the equation of motion? They're related to which two factors of the lungs? It's thoracic pressure, but I'll give you a hint. One is the resistive pressure.
Resistive and elastic.
Yes, elastic pressure, resistive pressure, very important. And although we get taught this in physiology, many people don't calculate it at the bedside. I don't calculate it at the bedside. You need to understand, because when it comes to recognizing how your patient responds to different modes of ventilation based on their condition, it tells you a lot about the patient. Not only that, when we get into asynchrony recognition, you have to understand which variable to look for on the ventilator, and it's based on this equation of motion. These are my disclosures, nothing related here. No one, even though there's Draeger ventilators, nobody there is paying me to say any of these things. So the objectives, we're going to discuss basically the overall goal of mechanical ventilation, review the role of compliance. I may interchange the words elastance and compliance. For those who may not understand, elastance is the inverse of compliance. It's whether you put volume or pressure on the denominator or the numerator. One is measured with milliliters, one is liters. But same idea. But when one is up, the other one is down. So. And then review the importance of breath timing for various modes and discuss suggested ventilator settings and how to monitor the patients based on the modes and how they respond to the equation of motion. So overall goals, I think, are very understandable. We have CO2 removal is basically maintained with minute ventilation, of course, unless you're receiving ECMO or some sort of extracorporeal CO2 removal. And for oxygenation, we provide PEEP and FiO2. Of course, we know that if we increase tidal volume very high, we actually can improve oxygenation, but what else can happen if we use high tidal volume? Was it a lung injury, worse outcomes? So in the ARMA trial, again, the ARDSNet trial, we had high tidal volume versus low tidal volume. They had better blood gases, better CO2 removal, better oxygenation, providing 12 mils per kilo, but they had higher mortality. So although these are the goals of mechanical ventilation, we should not be influenced by these values too much. We need to consider the lung mechanics and what happens when we try to achieve these things. So we control everything that's highlighted in dark blue there. We control tidal volume, we control respiratory rate, PEEP and FiO2, and depending on your mode, we may be titrating pressure to achieve the tidal volume, right, if you use pressure control ventilation. Just a quick show of hands, how many, there's standard mode for when you intubate and you start baseline, use pressure control. Okay, and who uses volume control?
Especially brain injury patients use
for volume control or for
volume
control? Okay. So I'm not going to tell you which is better, which is worse. I personally, when someone is passive, I like volume control because of some monitoring options, which I'll show. But pressure control is a very easy mode to utilize. When patients wake up, it's the first mode I would switch them to if they're not ready for spontaneous breathing. I would use pressure versus flow because patients are more dynamic and they might want to control a little bit of their flow, but we'll talk about reasons to use both.
Actually, we use the RBC for half an hour to see tidal volume achieved at which pressure.
At what
And
pressure,
also we can measure plateau and peak, there is equilibrium or plateau
Yeah.
pressure. Then shifting to the achieving tidal volume according to pressure. Change it to
Okay.
pressure.
I worked at a hospital, the primary mode was PRVC. I'll talk about issues with PRVC at one point today. It's the same issues with volume assist control, so I'll talk about those. But in general, you can provide, so the measurements we do to determine the elastic pressure of the lung, what holds do we do? Inspiratory and expiratory. You want to know the complete driving pressure, right? When you do a hold on the ventilator, the mode becomes irrelevant because you have zero flow. The mode is only based on the flow delivery. Once you hold the breath, however much volume is in your lungs, when you do an inspiratory pause, that pressure is the pressure required above, like total pressure required to put that volume in the lungs. It does not matter what mode you use. So it's very important that when you're doing inspiratory and expiratory pauses, it doesn't matter if you're using pressure or volume control. You can do these holds in either mode and they tell you the exact same thing.
I think patient should be paralyzed.
When you're doing holds, technically yes, but in pressure support, some ventilators allow you to do inspiratory plateaus, and they actually can tell you some information. I don't think I get into it too much, but maybe it's one of the did you talk about PMI at all? That's okay. It's okay. Not all ventilators can do it, so it's not something I generally focus on too much. Okay, so the respiratory system is made up, of course, of the airways, the lungs, and the chest wall, which includes the rib cage and the diaphragm. This is very important because when we think of the chest wall, we think the chest. We sometimes forget that the diaphragm and the abdomen is part of the chest wall. So if you have intra-abdominal compartment syndrome, it affects the stiffness of the chest wall. So when we are having difficulty ventilating, it's not always the lungs that are causing the problem. It could be that they have abdominal distension. So respiratory system mechanics is basically the function of the respiratory system as it relates to volume, flow, and pressure. The equation of motion, okay? Now, first, define compliance. It's the change in volume per unit change in pressure. This is mostly review for everyone, but this is always good to just make sure that we all get on the basics here. And of course, elastance is just the inverse. Okay, so it's the reciprocal of compliance, the pressure needed to provoke a unit volume change. And this is typically measured in liters, whereas compliance is measured in volume, or in milliliters, sorry. Now, resistance is the force opposing airflow in the airways, including artificial airways. Centimeters of water per liter per second. Here's the issue with resistance. Resistance is completely reliant upon how fast my flow goes into my patient. If I'm using volume assist control and I set the flow at 30 liters per minute, my resistive pressure will be different than if I use 60 liters per minute. It does not mean the patient is worse when I turn the flow up. You just have to understand it's a product of how fast we push the volume in. This is why we do things like inspiratory pauses and expiratory pauses to determine elastic pressure, because the resistive pressure can confuse things. In a patient with asthma, I'm okay if my peak pressures are 60, 65 centimeters of water if I'm using volume assist control. I honestly don't care. I care about my plateau pressure, because I'm expecting resistance to be horrible. If I put a very small tube in, my resistance will be higher. I'm expecting this. I want to know whether the lung distending pressure is the issue. So, this is the equation of motion, which includes PMUS, and I've also rearranged it. Sometimes you'll see it with elastance, volume, resistance, flow, plus PEEP. But and then the total pressure over here. So P vent is basically driving, it's the resistive pressure, not driving pressure, but the total pressure above P, because I've just moved it over and called it P vent. And of course, the total amount of pressure being generated, or the work being generated, essentially includes both when your patient's breathing. When they're passive, it's just P vent, okay? So the pressure and or effort required to ventilate the lungs due to the elastic and resistive forces. So when I asked you to summarize, the easiest way to explain it at the bedside, if you're doing bedside teaching, is not to say, well, if you multiply elastance by volume and add it to resistance, you just say it's a combination of the pressure due to elastance and the pressure due to resistance, okay? So when you do a pause on the ventilator, this is peak minus plateau, and this is plateau minus total peak, elastic and resistant pressures. Okay? So modes of ventilation are either, and this is where we know there's many names for modes of ventilation, but they all fall under one of two categories. They are either pressure controlled or volume controlled as it relates to the equation of motion. One of those two elements is being controlled. So in volume assist control, we control the volume and the flow. It is fixed. So if my patient has changes in respiratory system mechanics, let's say their compliance gets worse or their resistance gets worse, I'm going to see changes in the pressure. It is what is not controlled in this scenario, okay? So when we have a fixed flow, whether it's constant or decelerating, if we have patient breathing, these do not change. Some ventilators, I will say, will give it to you. If you demand a lot, we will give some, but by default, modes are designed not to do that. So if they make an effort, the pressure will drop. This is the patient effort. That's what you're seeing there, PMUS, the muscular pressure by the patient. And if the elastic load increases, so the lungs become stiffer, pressure will go up. If resistive load changes, again, pressure will go up. But across the entire, resistive pressure is all the way across you, okay? Now in pressure control ventilation, we are controlling this. So what changes when things change? Volume or flow, right? So if the patient takes more effort, flow will change and volume will change. If the lungs get stiffer, volume will go down, flow will go down. If resistance changes, this is all affected. But the pressure, the ventilator tries to maintain that pressure. It is controlled. Okay. Any questions so far? I feel like this is very clear baseline stuff, so okay, I'm building up to the important stuff. Now, because it's pressure controlled, again, if PMUS is present, if the patient takes a breath in, they can pull in more volume, and the flow becomes rounded. This is very important when I talk about asynchrony later today, that by default, there is a peak flow and it decelerates. Interestingly enough, it doesn't normally curve like this. It's usually a linear deceleration. I didn't make these graphics. But when someone is breathing, the peak becomes more rounded, and that's okay. And I'll point that out later. We can identify how strong someone is breathing sometimes by the shape of the flow. But that doesn't mean it's bad. We need to measure other things, which will be covered later, about how we can determine how strong the patient is breathing and whether that's a problem. But just seeing rounded flow is okay. If I put someone on CPAP, the flow is going to be rounded all the time. Okay? The elastic load, if it increases, again, we lose volume, we lose flow. And resistive pressure, same thing. Resistive pressure tends to flatten out the flow. It takes longer for the lungs to empty. With very high compliance, again, it takes longer, not to empty, for the lungs to fill, but also to empty. Okay, we've heard of the time constant. What's the time constant? What two things are multiplied by the time constant? Basically, resistance and compliance give you the time constant. So elastance, the inverse, resistance and compliance give you the time constant. That's what determines how much time it takes for your lung to inflate and deflate. So when we have patients with COPD, they may have high compliance if they have emphysema. They may have high resistance if they have COPD. Those lungs will take longer to fill and longer to empty, which is why when we try to hyperventilate someone with COPD, we end up with worse blood gases because we just start to trap the gas because they need more time to exhale. So when you have when you have a drop in compliance, this is what it would look like. This is your flow waveform. Let's say this is high compliance. If you had low compliance, the lungs fill very quickly. And if you have a set I time, you can see how you end up having a much longer pause because the lungs fill and then they just do nothing. They just stay at that level. With flow, when you have airway resistance, specifically in the airway, in the lower airways, it may not flatten out like this. You may still have a peak if there is, the large airways are okay, but you may have a peak and then it flattens out and takes very long to exhale. If anyone has seen an asthmatic patient on the ventilator, there's very long, flat expiratory flow that is caused. So you can see the effect on resistance both during inspiration and during exhalation. I already mentioned the time constant, but essentially it's the time required to exhale as well as to fill the lungs, but it depends upon the respiratory system. Time constant, which is compliance times resistance. And most of the lungs will empty at 95% of that time constant. Do I expect everyone to calculate time constant at the bedside? I don't. You just need to understand the components that make it take more time, and you need to think, do I have enough time to get the volume out of my patient? If I can't fix their resistance or their compliance, then I need to adjust the ventilator to ensure that I'm meeting this demand. But you don't need to know the exact number, you just need to understand the concept. Okay? And this is when we come into breath timing. So we have inspiration, expiration, and of course this gives you the IE ratio. Now, when we are in volume control or pressure control, where the timing for inspiration is fixed, if I increase my respiratory rate, what happens? Yeah, so this actually starts to do this, right? So if I'm just increasing my respiratory rate, I'm decreasing the amount of time to exhale if I don't adjust this. This is probably, as a respiratory therapist, this is the #1 problem that happens when physicians start touching the ventilator if they work in a hospital where it's mostly controlled by respiratory therapists. They go up, they look at the blood gas, the respiratory therapist is busy, they turn the respiratory rate up. And this is what happens. And then the blood gas comes back and it's worse. I increased the respiratory rate, what happened? You did not consider that the inspiratory time is fixed. Now some ventilators, you can set the IE ratio. So if you increase rate, it will maintain the IE ratio. It just means that it shortens your inspiratory time because it maintains the ratio. So depending on how your ventilator is set up, it may or may not be problematic for someone to walk up and turn the respiratory rate up. I once had a physician think they were turning the O2 up, and they turned the rate up to 80, and then quickly called me because the ventilator was alarming and going crazy. So I have no problem with physicians touching ventilators, but please maybe just familiarize yourself with the ventilator first. So, and of course, if you go too high on the respiratory rate, you end up with what's called inverse ratio ventilation, which this is definitely not sufficient. Some patients with very poor compliance can get away with a 1-to-1 ratio. It takes very little time for the lungs to fill, very little time for the lungs to empty. They have a very low time constant. But for patients with a high time constant, you're more likely to get into problems with this where they have insufficient time. Visually at the bedside, how can I identify that with this waveform? Is it my inspiratory flow or my expiratory flow that I need to look at?
Expiratory, because it's not returning to the baseline.
Exactly, it's not reaching 0, right? So this is the easiest way to determine. Now what's interesting is some ventilators like the Draeger, a message at the top of the machine will mention auto PEEP. And you know what the problem is that many people when they learn about auto PEEP in school, respiratory therapy, that auto PEEP, I need to increase my PEEP to match or to get to 80% of my auto PEEP. This is clearly a timing problem. This is not a lung mechanics problem, right? So the only time that PEEP helps, if you have auto PEEP, is if the patient has very tight airways, COPD, asthma. Those patients, when they're passive, you could put PEEP of 0 and still have a total PEEP of 10. And when you increase PEEP, you have to make sure that you don't push that higher. So some patients are what we call PEEP absorbers. So let's say my total PEEP, let's say I have PEEP of 0, my patient has asthma, and I do an expiratory pause, and my total PEEP is 10. If I increase my PEEP from 0 to 5, if my total PEEP goes from 10 to 15, I did nothing. I didn't splint airways open, I just pushed up the pressure. This is a non-responsive or non-absorber. If I increase my PEEP to 5 and my total PEEP stays at 10, or maybe it goes up 11, 12, they absorb some of that PEEP. The benefit of PEEP is there, meaning it will make them easier to trigger the ventilator, okay? If you exceed that, it becomes harder for them to trigger the ventilator. So when you have asthmatic patients, you actually want to do these maneuvers when they're passive, PEEP of 0, assess the total PEEP, start to titrate up PEEP and see what the response is to the total PEEP. But when it comes down to timing, you need to reduce your respiratory rate, that's it. This is the easiest auto PEEP to fix. If my ventilator says auto PEEP and I see this, I need to turn my respiratory rate down, or if my tidal volume is too high, turn my tidal volume down. And just reassess, obviously. So this looks like a little bit of a busy slide, but in terms of most of the common modes of ventilation, we have volume assist control, pressure assist control, pressure support, PRVC, and SIV. In terms of how the breath is started, so the columns are how the breath starts, how the pressure responds, how the volume responds, flow. So again, we have pressure, volume, flow, we have the equation of motion, and then how the ventilator decides to stop delivering the breath. Okay? So for volume assist control, it's based on whenever we tell the ventilator to give the breath. It's based on a set frequency Same with pressure assist control or patient triggered, so it's, when the breath starts is identical, right? Pressure support, it's patient triggered. Now, we could have auto trigger, other things can trigger a ventilator, cardiac oscillations. I've seen patients on dialysis where the pulsing of the dialysis machine was causing fluctuations because the catheter was beside the airway and you could see it in the flow. So things can auto trigger, but by design, we want the patient to trigger, that's pressure support. PRVC, same with other control modes. SIMV, it's sort of both because you have a combination of control and support. For pressure, as I mentioned, based on the equation of motion, we are controlling flow and volume. So any change, the pressure is determined by respiratory system and patient demand. So whatever the patient is doing or what their lungs are doing, the pressure will change, this will not. Of course, it's the inverse with pressure control. This is controlled. Volume will be based on their respiratory system mechanics, and flow is variable. It will change also based on the respiratory system mechanics. In terms of cycling off, it's either flow-based, so if I set a flow of 40 liters per minute, and I have 400 mils of tidal volume, I'm not going to do the math, but basically it's going to cycle off when that flow rate reaches 400 mils, it's going to cycle off. Some ventilators we can set a specific time and it will determine what the flow is, and usually you can push a button to see what your flow is, but that's a fixed rate, or a fixed flow rate. And then of course with pressure assist control, it cycles off based on the time that I tell the ventilator to stop. In pressure support, it's the percentage of peak flow. The issue with this is every ventilator calls it something different. The PB calls it E-Sense. I don't think that's a useful name, to be perfectly honest. Other ventilators might call it PSV cycle, which makes perfect sense. It's the cycling of the pressure support ventilation, or inspiratory cycle percent. Everyone calls it something different. Just understand that's what determines when the breath cycles off. More about that when I talk about the synchrony later. PRVC. The issue with PRVC is that most people feel it's like pressure control, right? Because under the hood, it is pressure control, but, so although notice how it's not saying it's controlled by pressure, because every time the respiratory system changes, if compliance changes or resistance changes, this pressure is not controlled. The ventilator adjusts it. So although the mode is a pressure controlled mode, it has what I used to joke is a respiratory therapist in the machine that turns the knob if the compliance and resistance changes. So it's turning the pressure up or turning the pressure down. And so the volume is targeted and it adjusts this, but we can't, if you set PRVC and your pressure is 25, your peak pressure, it can change. You could come back an hour later and it's 30 because respiratory system mechanics can change and it's trying to target the volume. So yes, the flow is variable. It will be different based on what happens when it tries to target this. And then of course, I time is here. Now I'm going to quickly stop here for a second and tell you some of the issues, unless I have it here. Let me just see. I have it here, never mind. I'll get to it in a moment. Okay, and then SIMV, again, we have a set frequency or patient triggered as well. So we have control plus pressure support settings. So take any of the control settings and pressure support, and this is what you end up with, essentially. Now, SIMV is a tricky mode to discuss because it was designed for weaning, right? You slowly reduce the respiratory rate and allow more pressure support breaths. When they studied the effect of that mode as a weaning mode, it failed horribly. It was not the best way to wean patients, and this was established in the 1990s, and yet it's still available on modes, and some people still, it's used a lot in pediatrics. I can't argue against pediatrics. I've lived most of my life as a respiratory therapist in adult care. But in the adult ICU, I call it a nuisance mode. I think most respiratory therapists use it when the patients are going apneic, but you show up to the bed and they're awake. So you're like, well, I'll just give a backup rate, so you set SIMV. And I'll talk about why that happens when we talk about asynchrony, and then maybe you'll never have to use SIMV again in adults. So I've already highlighted all of the points at which the equation of motion affects the mode of ventilation. So in terms of common settings across all modes that I just discussed, again, I only was talking about common modes of ventilation. There's of course PAV, NAVA, which I'll talk about later. There's airway pressure release ventilation. There's all different types. I just talked about the most common ones because let's be honest, even though we may have played around with those modes, most people either use volume assist control, pressure assist control, maybe PRVC, and pressure support. Those are the most common ones utilized. So what's common amongst all modes, of course, is the FiO2, PEEP, and trigger sensitivity. which is just the criteria at which the ventilator decides to give a breath to a patient when it senses that they demand it. So volume assist control in terms of common settings, the respiratory rate per minute, of course, is the frequency. It's called frequency on many ventilators. We target 6 to 8 mils per kilo of ideal body weight, and 4 to 6 mils typically for ARDS management. Sort of the sicker they are, the lower we put the tidal volume. This is generally because the amount of pressure that is required to ventilate along with very poor elastance is much higher. Again, it all relates to the equation of motion. Flow determines the time it takes to deliver the tidal volume. An inspiratory pause, so this is one of the few modes that allows you to set a dedicated inspiratory pause time of like 0.2 or 0.3 seconds. And what that will do is stop flow. Remember I said when you do an inspiratory pause, the mode doesn't matter anymore. The pressure on the ventilator is what is required to have the volume in the lungs that we just pushed into the lungs. So you can set this, and it can distinguish resistive and elastic pressures at the bedside. And I'll show you a screenshot of my favorite way to set up a ventilator. When the patient is passive, I will be very clear. If my patient begins to interact, I will immediately switch to a pressure targeted mode, whether it's pressure support or pressure control. So for pressure assist control, frequency is the same. We adjust the pressure for the same tidal volume targets essentially. Inspiratory times, the length of time the pressure is maintained. We have to make sure there's sufficient time to exhale always. You're always assessing your ITE ratio, make sure it's sufficient for the patient. And the rise time is the time it takes the ventilator to reach the set pressure. The default is normally okay for most patients. For people who obsessively adjust it, we have to understand that when they have studied it in awake patients, that rise time, it has a U shape for comfort, meaning too slow, it's uncomfortable, there's a sweet spot, and then it can go too fast and it becomes uncomfortable. So there is a sweet spot for patients. It's not something it's not the first thing I would adjust if my patient looks uncomfortable on the ventilator, unless it seems to be very slow at pressurizing. Or if it's really too fast, you just get an overshoot of resistive pressure. The patient may not be bothered by that. So special considerations for monitoring. Hopefully nobody saw that. I'll put it back to you, can take it in a moment. But let me ask you a question. So in volume assist control, based on this, what is the most important thing to monitor? Think of the equation of motion. What's the most important alarm to set?
Resistant.
My tidal volume is controlled. I'm not expecting that to change at all.
BB, because it changes according to resistance, maybe if your water in circuit piping something, maybe increase the BB.
Yes, sorry, I misunderstood. You're saying PP, yes. Yes, so if you're using volume assist control, the most important thing to measure or to set your alarms properly is not tidal volume. That's set. You could do minute ventilation, because if your patient starts to breathe above, your minute ventilation can go up, sure. But pressure is the most important. That is going to change, and it will tell you that you need to go in. Now, if the pressure, let's say your peak pressure alarm goes off, is it resistance or compliance? We have to check. We don't know. We don't know. Now I'll show you how I set up the ventilator and volume control that I would know immediately from outside the room, whether it was resistance or compliance. Now, what's the most important thing to monitor with pressure control? Volume. That's what will change. So your patient's lungs could be getting worse. The pressure is not going to go up. Now your patient could cough, of course. There's reasons your pressure alarm can go off in pressure control, but it's not going to be from just simply changes in respiratory system mechanics as time goes on. Now PRVC, I'll tell you, PRVC has an addition, so obviously tidal volume won't change, but pressure will change, so it's important to monitor pressure. But many ventilators have a low inspiratory pressure. Again, not likely to go off in pressure control, because we're controlling the pressure, the ventilator is always going to put a control there. But in volume control, you may have a low pressure alarm if the patient is really demanding flow. PRVC as well. If my patient's working harder and harder, what happens to the pressure? Let's say, I'll give you an example, we're gonna get into this so I can just go fly through my slides very easily. But in PRVC, if it's pressure regulated volume control, for those who don't know how it's used, you set a target tidal volume and it automatically adjusts pressure control for you, which sounds great. But let's assume I set 400, my patient wakes up, they pull in 500. What's the machine gonna do?
Nothing.
Well, it's gonna decrease the pressure, reassess, patient goes, oh, that's harder, now the patient they want 500. Remember, the patient wants 500. So they pull in 500, what does the machine do on the next breath? Drop again. They pull again, drop again. So the hospital I recently worked at, their default mode was PRVC. And anytime the nurse called me and said, the low pressure alarm was going off, I said, did you mean sedation? I said, yes, okay. I would say 6 out of 10 times, I said, I'll be right there. Before I get to the bedside, you know what they've done?
You start the sedation.
Increase the sedation. And I have to explain to them, please don't do that. I said, put it back where it was, and I will wait here, and I will adjust the ventilator. I just switched the ventilator to pressure control. And then I say, when they wake up, that won't happen again. They'll get whatever they want, and I'll come back. But these patients were waking up, demanding more volume than I set, even just 100 mils, which I'm not concerned about that, unless they were requiring ECMO, like they're that sick. But if they're just a standard patient, I'm not worried if they get 100 more mils of tidal volume. So this is important to understand what it's telling you. Because the nurses did not understand in my hospital. They would just, and I said, I would tell them, I'll be right there. And I would literally walk from the respiratory therapy department to the room, and I said, they just looked really uncomfortable, so I increased sedation. I'm like, that's, anyways. So this is a problem, right? We have to understand what the mode is telling us. I worked with some respiratory therapists that would go and adjust the alarm. I'm like, do you not realize what it's telling you? So it's telling you something, right? And all you have to do, what's that?
Patient is demanding more.
They want more volume. So whether you increase the volume, I would say just switch to pressure control. You know what pressures they need, just switch that, or try pressure support. Let them have more control. You don't have to switch to pressure control. The only time I would switch to pressure control in a patient who's active versus pressure support is if they're not quite ready for spontaneous breathing. Maybe they don't have the strength to get a deep enough breath, whatever, or maybe they're developing ARDS and we're thinking whether or not we should sedate and paralyze. I may use the pressure control, because the difference between pressure control and pressure support is how it cycles off, right? If you look at this graphic here, pressure control and pressure support, aside from the trigger, so if the patient's triggering every breath in pressure control, this is the same. Same. This is the difference rate. Okay. Okay, so now I've answered most of my questions. Peak pressure and plateau is extremely important to monitor. How do we monitor plateau with an inspiratory pause? How long do you hold the ventilator for an inspiratory pause? And I'm gonna get wrong answers. I want wrong answers.
5 seconds.
5 seconds, wrong. We're all taught this, by the way. I was taught 5 seconds. Okay. Anyone else? So 5 seconds, anything? Any longer, shorter?
Some say 6, some say 3.
Getting closer with 3.
2, 3, 4.
Short pauses. Okay. The recommendation is actually less than or equal to 0.5 seconds. Why is that? The longer you hold, think about this. How much pressure do we put in the endotracheal tube cuff? 20 centimeters, like usually no more than 20 centimeters of water. If I do an inspiratory pause and the pressure on the ventilator is 30, what can happen? You get a very small leak during the hold. So this happens one of 2 reasons. This could be what's called stress relaxation. So when I do an inspiratory pause, there's areas of the lung with different compliances. So we have a little bit of pendulum happening. So volume shifts to other areas of the lung. Or I may have a leak, a very small, quiet leak around the endotracheal tube. So the longer I wait, the less accurate my plateau pressure measurement is. Okay, so 0.5, and you can, I have the reference up there as well. So very important, 0.5 seconds. And this is why when my patients are passive, and I'm not telling you if you use pressure control or PRVC, I'm not telling you you're wrong. I know in their hospital they use pressure control mostly, but this is the beauty when you have a passive patient. Pressure control doesn't give you the option to set an inspiratory pause, but in volume control I have an inspiratory pause. And it's set at 0.3 seconds. And notice, so on this ventilator, if you don't have a pause, your plateau is three asterisks. It's just 3 symbols, there's no number there. When I set it like this, I have peak, plateau. I have my peak down here, tidal volume, everything is here. This ventilator, if I push this button, would show me driving pressure because it can measure driving pressure now. So with this, now, I'll give you another hint. If you use 60 liters per minute of flow, remember resistive pressure is centimeters of water per liters per second. So if I convert 60 liters per minute to seconds, 1. So if I set it at 60, my denominator is 1. So it's literally peak minus plateau divided by 1. What's my I use 60 liters per minute of flow. What's my resistance right now? 8. And that's an accurate measure of inspiratory resistance. My resistance is 8 centimeters of water. Am I worried about that? I'm happy with 10. Once you get over 15 on a patient, that's high resistance. But an intubated patient, 10 to 15 is normal, acceptable, and the tracheal tube size will highly impact this. And of course, your flow settings. If I turn my flow down to 40, this difference will change. But when they measure in studies, they usually use 60 liters per minute of flow because the denominator is 1 and it's a very accurate measure. It's a consistent measure of resistance. So I know at the bedside this is it. So I get called to the room because my peak pressure has alarmed. How can I tell whether it's resistive or elastic problems? Simply by looking at the bedside. Which numbers will change if it's resistance problem? Patient has more secretions, I need to suction.
Ratio.
The ratio. Can I say it again?
The ratio.
The ratio? No. What changes with these numbers?
No, there is a secretion. You can see on the graph.
So if I walk up to the room, this is still 23, 24, but this is 38. I know my patient probably just needs to be suctioned. It's a resistive problem. Now, when compliance or elastance changes, they both change. So assuming resistance is unchanged, both of these, the difference would still be 8, but this might be higher or lower. So the peak pressure goes off. When you go back to the bedside, all you need to know is whether this has changed. Because you know your alarm's gone off, so you know this is up. Before you get to the bedside, they say peak pressure went off. You know if you set your alarm at 50, you know that you were at 50 now. The question is which one of these has changed. If they've both gone up, the patient's lungs are more stiff now. Other uses in volume assist control, if you use flows, again, generally 40 to 50 is ideal, but the shape of the pressure time curve, notice this patient here, whoops, I just stuck the cable. Notice how the curve looks relatively straight. I would argue that it's not like this, and I would argue it's not like this. But the pressure time curve actually tells you a lot about the patient. This is something called the stress index. So when you look at when the flow is constant and straight, the curvature of the pressure time curve tells you a lot about what's happening to the patient. This is a lung that is continuing to open or recruit. You may have some tidal recruitment. So from baseline alveoli might be opening. This straight line indicates that your lungs are open. There's no changes. It's a linear, think of your pressure volume curve. Essentially, if the pressure time curve is straight, it's linear, the lung is essentially open, there's no tidal recruitment. When it has an upward curvature like this, in a pressure time curve or pressure volume curve, this would be your duct build, you know how it starts to curve outwards? This just tells you that perhaps the PEEP is too high, the lungs are too, or the tidal volume is too high, but there's potential for over-distension. The rise in pressure is not linear. It increases faster than it should. So this tells you, again, if you were adjusting PEEP, this is PEEP is too high, PEEP is too low, PEEP is ideal. So in pressure assist control, we already discussed tidal volume and minute ventilation is what you need to monitor most importantly because it's going to change. And of course, there's other comments here, but essentially, yes?
How frequently can you set?
So if you're setting your alarms, that's very helpful. But in terms of frequency, I don't know that there's any evidence that one is better than the other. I've worked at hospitals where it's every 2 hours, every 3 hours, and every 4 hours. During COVID, we did twice a shift if we were lucky. Because the patients who were the sickest, we were there a lot. So during COVID, if your patient was stable, you would check them in the morning, like after shift report, usually 3 times a day. Halfway through the day, and then at the end of your shift. So every 6 hours we would do during COVID. Because the patients that needed your attention, you were there every hour, every 2 hours. So yeah, the ideal option is, depends on your staffing, depending on how many people you have monitoring your ventilator. This is why the alarms are important, but ensuring that you set the alarm is going to tell you the most information.
It's actually unclear. It's open to research. If you look at the ARMA trial or most mechanical ventilation trials, 1 measurement per day during rounds. And that basically led to landmark trials which guide our clinical practice. So we don't know if we should measure once or many times a day. It's intuitive that we should probably measure frequently, but there is no data to support or guide how often we do.
And understanding your mode, so in terms of doing the measurements, so I guess the question is how long do you monitor a ventilator, like look at the numbers and write them down, versus performing maneuvers. And I would argue that you know if you should perform a maneuver. Because if you think about the equation of motion, if you're in pressure control, if the last time you looked at the patient, the tidal volume was 400 and now it's 300, you still don't know if it's resistive problems or compliance problems. So this is where a pause may tell you more information. Is your plateau different? Is it the same? If your plateau is the same, your lungs got stiffer because the volume is less and your plateau is still the same. Your driving pressure is the same. So let the changes that occur guide whether or not you do monitoring. So in some hospitals, they may say, do driving pressure every single time you see the patient. Okay, but if your peak pressure hasn't changed, you assume resistive pressure hasn't changed because it would have gone up since the last time. So again, if you're using volume control, if your peak pressure hasn't changed, plateau has not changed. It hasn't gotten worse. It could have gone down and resistance gone up, but again, you would probably have other things indicating this. So let the changes that occur every 2 hours when you're just doing regular monitoring or every 3 or 4 prompt whether or not you're doing measurements. But I would argue every major round, we call them, like the first time you see a patient in the morning, it's a good practice as a respiratory therapist, I would say, to do these inspiratory pause and expiratory pause.
That's what you do in the hospital.
Perfect.
But the thing is, how frequently should you do it?
Yeah, I would say minimum, the first time you see the patient, really get a sense of what is my true plateau? What is my peak pressure? What's the difference, etc. And then moving forward, you should know based on what mode you use, whether or not you should pay more attention to what's happening with that patient. Because it does provide valuable information. But if things aren't changing, it's not going to tell you anything, and it's just a waste of your time. So I'm reasonable. As much as I love this stuff, I know it's time consuming to do. Wait till we get into RI ratio. Yeah, that's okay. Talk about time consuming.
This field is evolving very fast.
Absolutely.
You'll talk about the asynchrony. If we find out, for example, that addressing asynchrony will improve outcome,
right?
Then the monitoring needs to be
becomes more
constant.
Yes.
Yep. Okay? So it will be extremely personalized. So it's a very much evolving field. And you don't have an answer yet.
Yeah, there is likely also heterogeneity in the sense that if you have a young post-op patient, healthy lungs, then you probably don't need to measure every hour or every 2 hours. But if this is a patient who is hanging on the cliff and is very close to getting ECMO, that's a patient where you need to be on top of things and monitor more frequently and see what's going on.
Yeah, but that's a very good point. If we start learning that certain asynchronies are linked to poor outcomes, I'll tell later some asynchronies may indicate your patient's just ready to come off the ventilator, so we shouldn't use sedation to manage it. But you know, Lorenzo's right, it may require more monitoring. And this is where we would need the assistance of the ventilator companies to build in tools, because we can't physically stand at the bedside all the time. We need to be able to recognize it, and if recognition can be better utilized with software, computer software, AI, whatever, then as long as the clinician knows what to do with that before ventilators do it automatically, this is really for future research. But just another point, look at my plateau pressure. It's a very long plateau pressure. I'd say anywhere between like 5, this is about a 5 or 6 second hold. Look at my tidal volume. I have a leak, right? So this is not where you want to measure your plateau. You actually want to measure it right there. And notice the difference that my measurement would have. Okay. So even in pressure control, and I'll tell you, there's some patients that I went to the bedside, I would not bother doing an inspiratory pause on pressure control. I'll tell you which ones I would. You see the flow here? See the flow? It's not reaching 0. I know if I do an inspiratory pause, I will have a lower plateau than the pressure that's in the ventilator right now, because I have not filled the lungs to capacity. I know that so this pressure is somewhat resistive, some of it. When I do a pause, I'm expecting a drop. If I walked into a room and this waveform was all the way down here, and there's a little bit of a pause, it's not going to tell me anything different. It's actually it'll be the same pressure, because the peak inspiratory pressure would be the same as my pause. Okay, I've already talked about the issues I had with PRVC, so we can skip right ahead. Just perceived benefits, of course, we say, oh, lower peak pressures, because if the lungs are improving, it will turn things down. It also turns things down if the patient wants more, so you have to understand what's going on, and I've already talked about all that. So I would say patients with an intact respiratory drive will likely tolerate pressure-targeted modes over volume or flow-controlled modes. So I mentioned I like volume control as a monitoring tool in passive patients, but the minute my patient becomes active, pressure-targeted modes are more comfortable. So in summary, the goals of ventilation are to assist or take over the work of breathing required for lung function. Modes of ventilation respond very differently to changes in resistance and compliance, the equation of motion. They affect the timing required for full exhalation, and many monitoring options exist. The basic monitoring of resistance and compliance can assist in clinical decision making. How often we measure should probably be based at least once per day, but then if changes are happening, again, the changes you would expect based on the equation of motion should impact that.
You should advertise those because they're very nice.
Yeah, so I'm the editor of the COMV blog. It's the Center of Excellence in Mechanical Ventilation. Although I no longer work in Toronto, I still maintain the blog. It doesn't get updated nearly as frequently as it did when I did work there, but I still am the editor, and if anybody has questions or comments on what they'd like to see on the blog, they can send me a message. And of course, I will talk about the calculator later. Some people who advertise the calculator will say rtmaven.com, but it all points to the same calculator. It's just an online calculator that can help you with esophageal pressure measurements, improvement to inflation ratio, POC movers, etc. And that's my own personal coding calculator. So let's take a break. Of course, we're not on schedule, and that's okay. We'll line things up eventually. Hopefully, everyone's still enjoying themselves. Let's take maybe a 10-minute break. Just stretch your legs, use the washroom, and grab a drink, and then we'll be back. Okay.